So I didn't know that that was coming before our piece. I think we're all still immobilized by Kriya's sharing of her story. Had the pleasure as a part of the stakeholder panel to meet Kriya and was immediately impressed. I think now I'm kind of overwhelmed. So good morning, everyone. My name is Nancy Norman. I'm the Medical Director of Integration at NBHP Beacon. I've had the pleasure of working there for the past 5 to 6 years on projects that really have at the core of the work of transforming our system, the kind of work that Kriya is doing as a community health worker. I had a completely different set of comments to open our panel, but I have to admit I am still just stuck on the story that she shared. And if it hasn't been written up and published somewhere, it needs to be, because it is truly the model story of all of what I think it is we've been talking about. And I've come to realize over the years of being a internist and public health official that the pieces are really there, and especially from an internal systems perspective, sometimes we just have to stop and realize as a part of systems, we're mainly a part of the same community that we're often talking about that is trying to transform into something different. And I think if we take that perspective, I know I talked about humanity yesterday a little bit, and others have stressed that as well. If we really do stop and realize that we are a part of this whole entity, that sometimes it's a little easier to move forward and think about transformative efforts that can really have some sustainability. Folks have talked about models and how those models, changing models, can make a difference. Sometimes reorganizing can make a difference. But transformation is really, I think, a powerful thing, and I do feel as though that's the time that we're in. This entity of mental health and behavioral health. Even I, as a public health official, remember when I was chief medical officer for the city of Boston, also the commissioner for the health department for an interim period of time. And one of our major areas of focus was around health disparities, eliminating racial and ethnic health disparities. And that's still a big part of the work that's being done within the city of Boston. I remember at different meetings, I'd occasionally have people come up to me and talk about, this is great work that you're doing, really excited to hear about it, but how about the piece around mental illness? How about the piece around severe and persistent mental illness and the disparities and inequities that are there? And I would listen, and I have to say that even I, in what I think is a pretty progressive mindset, could not wrap my hands around that piece. Because even I, as a provider, often thought that behavioral health, mental health was kind of pretty happy out there on their peninsula. Part of the healthcare system, but different. Healthcare was all about internists and specialists, but psychiatry and mental health, it was, you had a person who had a diagnosis, you connected them to the right people, and they went to someplace different. And so, I share that to say many of us are coming out of the darkness and realizing that's not the best approach. And some of this transformation you heard about, the ACOs and how they're going to move forward and hopefully make some significant change, have as a part of their new structure something called community partners, and they're mental health community partners. And those mental health community partners are agencies that have been around for a long time. But I think part of what's so important of how the state has structured the connection and the work that they're going to be doing is to elevate, maybe an insulting word, but to give them more visibility. So the work that they're going to be doing, it's not about like, oh, you've got someone with a behavioral health, mental health issue, you're going to send them over here. You're really going to work in partnership with these community-based agencies, get to have a better sense of what these community-based agencies, especially from a medical perspective, are doing, and hopefully work better together to coordinate care. So I think today, our panel is really going to address some of those issues. What happens within communities, nurse who's been doing that for thousands of years, is going to talk about the work that she has been doing, a service provider based within a community mental health entity is going to talk about the work that they have been doing in partnership with others, a physician, a psychiatrist working with DMH who's committed to improving many of those outcomes you saw and heard about with early morbidity and mortality for a number of members, and also a doc who does some amazing research that has many of the components connected to community, academia, et cetera. So I'm really excited about our panel. I'm going to ask them as they each speak. Paula is going to speak first, followed by Gary, and then Dan and Vicki, to just introduce themselves and then talk a little bit about what it is they're doing. And we really want to have time at the end for questions. So let me turn it over to Paula.
Well, hi there. My name is Paula Richard, and I'm a nurse. I work at Corrigan Mental Health Center in Fall River, and I'm employed by DMH. I've been happily employed for over 3 decades. I am a registered nurse, and I work in an environment, it's a community mental health center, which is different than certainly our chronic care facilities. We have a variety of services at a CMHC. We may have an inpatient unit, which we do, but then there are well over 1,000 other patients that we take care of in the community and that have serious mental illness and need outpatient services, partial hospitalization, and supports by our current CBFS team, and I think they talked yesterday, soon to be the ACCS team. And I thought that I would just talk to you a bit this morning, just from a nursing perspective, this larger issue, bridging the divide. It's probably been the bane of my existence as a nurse. To healthcare disparities, a sincere interest of mine, both in all disparities for the seriously mentally ill. So, Sheree, thank you for that story that you told, and I would suggest that we book you at the Mass Nurses Association convention so that they can really, it's really well worth hearing. Okay, so what I'm going to talk about is, I know that yesterday it was said the budget is good and that's all fantastic, but there is still only so much money. So my focus today would be what we can do with what we have and what's right around the corner, July 1st. And one thing that's important to nursing is with the new MBHP partnership, DMH will have a new program, which is the ACCS model. And there's, as far as care coordination or full integration of psychiatric care and medical care, there's a health information technology component there where we will be able to look at the record for the first time for patients that we share. And we would be able to see, as a mental health nurse on a given day, I couldn't tell you if my patient went for her breast cancer screening or she had her colorectal cancer screening. But these will be outstanding items, if you will, that all providers of care will see, including mental health nurses. So we could intervene where we couldn't before. Some other programs that we already have, we have programs that, you know, of the 5 cancer screenings that I'm going to briefly mention, colorectal cancer screening is a very complicated there's a complicated preparation the day before. And for any who have had that special 50th birthday present, you know it can be really challenging, and our patients struggle with it. Therefore, they just do not do it. So we do have some resources now. We have respite beds, DMH-sponsored respite beds. In the respite programs, there is a mobile respite component where our patients could be supported to have that is the most complex screening to prepare for. And we've used these beds that way before. We have what we call the MIMI beds for medically ill, mentally ill individuals that we just admitted one recently who is diagnosed with cancer. So I think that creative use of the existing resources that we do have, including especially the mobile respite component, where if a patient was having a procedure like that in the morning, a mobile respite team member could go out, help them with the necessary preparation, do the transport to and from. Using public transportation is not a great idea. There are 3 cancer screenings for adults, and they are the breast cancer screening, the BRCA-related genetic testing, cervical cancer screening, colorectal screening, and lung cancer screening. That's what the U.S. Preventative Services Task Force still recommends. They have actually eliminated a few, if folks aren't aware. So the last thing that I'll talk about, those are the DMH resources. I think that could be used creatively, is better use of privately sponsored resources, such as I work in the Fall River area, and South Coast is a very big provider in that area. They have 3 very large wellness vans, and they make scheduled stops in various parts of the city where there are needs. It's a pre-scheduled situation, and they're run by registered nurses, and they're our patients, because transportation is the issue. I think we could make better use there. And they do offer testing if you do not want colorectal cancer screening, such as the FIT test, which is a test that's less invasive, and it's an alternative, and it can detect small amounts of blood in stool. And personally, as a nurse who's worked half my career in the community and half in the hospital setting, I'd like to see DMH's Healthy Change initiative just float more into the community, and I think we have the right resources just around the bend to do that. Thank you.
So maybe before Gary just speaks, Paula, if I could just ask one quick question as I listen to all the details. How do folks within the community connect to those services? Do you find that, especially for patients with severe and persistent mental illness, that they know about those options and they find you, or that providers know that you exist and they know which of their clients would benefit and they make the referral? Or do you find that you or those services are usually needing to go out and find people to say, hey, you could benefit from doing the screenings this way?
Well, the benefit of working in a CMHC is that the care is so integrated, inpatient and outpatient. So because our folks are DMH eligible, there is one program, the Community Crisis Stabilization, where you don't have to be a DMH individual to be, So I think that education amongst healthcare workers with DMH, that services like this are available, and we should look at them more, use of them in a more creative fashion. I think it will definitely take an educational piece for nurses, for instance, that work in DMH.
Great.
Thank you.
Thanks. Gary, I know you were going to talk a little bit about
Good morning. My name's Gary Hodgetts, and I work for North Suffolk Mental Health Association. I've been there for 5 years, and for 4 of those years I had the privilege of working with CREA. I'm currently the manager of our NIMH program, which is medically ill, mentally ill, and we specialise in providing treatment to people with both complex medical diagnoses as well as serious mental illness. So one of the challenges that we face a lot in our group home is a lack of training. I'll be totally honest. It's a lack of resources to adequately trained personnel. So this, I wish, was a joke, but it isn't. A gentleman at one of our residences, he signed a full MOLST. So do not resuscitate, do not intubate, do not hospitalise. The response to that was to buy me an AED. A defibrillator. So I think that just goes to show the insight that he's being given from a medical standpoint. I'm hoping that with Access, this will bring us some more training. This will bring us some more resources to better train personnel. One of the great things that NIMH has been able to do is keep people out of nursing homes who would normally be in a nursing home or would normally be in a hospital. If they're with us, they have a much higher quality of life. A lot of what we rely on is people being compliant, people following doctors' recommendations. And at times, I think it's natural that people get upset or get frustrated when somebody won't follow the recommendations of very well-educated providers. We provide services to an individual right now with, started out stage 4 lung cancer, spread to the sacrum and into his hip. So the one side of his hip is being held together by pretty much nothing. It's being held together by a wish and a prayer. That hip could go at any time. And the recommendations were for him to have surgery for this. He doesn't want surgery. He doesn't want the anaesthetic because the anaesthetic gives him a headache. When we say, so we could look at that as being a refusal to comply with recommendations. That's what it looks like to the outside. But because of our level of knowledge of this person, we can sit and we can talk and we can find out what the real reason why is. The real reason why was in the mid-80s, the last time he had anaesthetic, he was given ECT. So he associates the chronic headaches with the anaesthetic, not with the ECT. So that's an opportunity for us to sit with him and to educate him. Now, we know that in the group home. His providers may not know that that is why he's not being compliant with treatment and why he's not being compliant with recommendations. So what we've managed to do is we've been able to effectively communicate with his providers, with his VNA. We're very lucky. We've got an excellent VNA that comes to see this gentleman who will pass on information to everyone involved in his care. We have, as of right now, until July 1, we have a medical services team, which has 2 nurses that come to the programme. It also has a visiting prescriber. That will change a little in July. I'm unsure how, but we'll make it work. I just want to say that communication is key. It's not just communicating amongst ourselves as providers. I've been there. Before I came to this country, I worked as a nurse, as an RMN, a registered mental health nurse in hospitals in the UK, and I've been on that side as the nurse where people from the group homes are coming to me saying, hey, we need you to get the doctors to sign this, we need you to get the doctors to sign that, can you explain this to us? And I'm like, I really don't have the time to do this. But by me not taking the time to explain something to a group home staff, that means that our patient is going to suffer in the long run. Because often when they're sat with providers and they're sat with clinicians, they're not asking the questions that are on their mind. They're asking the questions to the group home staff. Because as Kriya said, the group home staff become family. And who do you go to in your time of need? Who do you go to when you're unsure of someone? You go to your family. The way that we can improve the care that we deliver to all of our patients is to increase the level of training to our direct staff. You don't have to be a clinician to make a difference in someone's life. You don't need licensure to make a difference in someone's life. You just need a big heart and you need to care. And I think Kriya epitomised that. Thank you.
So before Dan makes his comments, Kriya, I know you were outside when we took our seats. I just want you to know that this panel has been renamed as the We Want to Be Like Kriya panel.
Right.
Because we were so moved by what you said and what it is you do on a regular basis.
I just very, very briefly.
Sure.
I think what you said was so important and wonderful. How many beds does Mimi have?
So Mimi has 4 beds.
I just want to say that out loud. Mimi has 4 beds for all of North Suffolk Mental Health Association. If only all of our patients could be served by a team like that. It has 4 beds. That's not enough.
So another thing, one of the hardest parts of my job and of the job of one of the nurses who comes out with me, who will be speaking later, is we go and we see so many people who would benefit from the service that we provide. We have a wait list for the service that we can provide. We have 4 beds.
No, go ahead.
Okay. Morning. I'm Dan Breslin. I'm one of the area medical directors from the Department of Mental Health, which means that I work in the northeast corner of the state with providers of DMH services as well as DMH case management. And I also work with Dr. Sanders here in central office on issues around health and wellness pertaining to DMH clients across the state. My career began, though, back in 1981 when I was a mental health worker at the old Mass Mental Health Center when it was still an inpatient program. And I've spent, except for 3 years when I worked at McLean, I've worked in the public sector my whole career. First at Westboro State Hospital, Cambridge Hospital where I trained, and then Tewksbury Hospital before becoming an area medical director. I'm here today to say a few words about the system changes in DMH, but I think it's important to link that to what Kriya was saying before, because I think that what has actually driven excellence in public sector mental health treatment forever has been the dedication of individuals who have been willing to go above and beyond, who are motivated by a compassionate connection with the people that they work with, that have a sense of justice and equity. And in many cases, those qualities are fostered and developed because of experiences of individuals and their families or in themselves of having dealt with mental illnesses. Because in fact, mental illnesses are among the most common chronic illnesses that we have, and certainly the most common chronic illnesses that cause disability. I think, though, and what motivates my involvement in my position is that we really need to move towards a system in which we do not rely on the personal commitment and the personal sacrifices of individuals like Kriya, like Gary, like Paula, like Kelly. What we really need is to move towards a system that can actually provide for the needs of individuals. There's a couple of people have mentioned during the conference that the average age of death of DMH clients is in the early 50s. So a picture speaks louder than words. I wanted to show this data which we put together, and just to kind of walk through, this is data from the early 90s of the average age of death of DMH clients, the earliest that we were able to find. And this is data from the mid-2010s from our deceased client profile in DMH. And as you can see, the blue or male, red or female, I didn't have a gender differentiation from this data, but as you can see, that the average age of death of DMH clients in the early 90s was in the early 50s. And it's still that way now. But what I've also added to this slide to kind of illustrate the extent of this problem is that although the average age of death hasn't changed, the problem is really getting considerably worse. Because I've plotted also in this graph the average life expectancy at birth for the general population of Massachusetts. And this first data point here is in 1991 when DMH clients were dying in their early 50s. So they were people that were born in about 1940. And if you jump back to 1940 here and see what the average life expectancy at birth was of people born in 1940, it was 65 or a little over. So 25 years ago, DMH clients were 15 years behind the Massachusetts general population. And while the average age of death has not changed over the last 25 years, look what's happened to the life expectancy at birth for people born in Massachusetts. So the problem is getting worse. It's not even staying the same. People with serious mental illness are dying of health disparities earlier relative to the general population than used to be the case. The other point I want to make is I think there's been a lot of speakers here who've really characterized that what a cancer diagnosis means, what the care needs of cancer mean for somebody with serious mental illness and what's needed to support people through their illness. But one point I really want to stress, which is something we're very aware of and concerned about in the Department of Mental Health, is that cancer is not the only issue. In fact, it's not the largest issue. So this is a graph that shows rates of serious medical issues that are plotted based on, sorry about that, the mass general population are the blue bars, people who are current smokers are the orange bars, people who have serious mental illness are the green bars, and smokers who have serious mental illness are the purple bars. And as you can see that for stroke, heart attack, COPD, and asthma, each of those categories greatly steps up the prevalence of these chronic illnesses. So this is just one indication of how it is that mental illness is associated with chronic disease of all sorts, and that the early mortality is very tied to that, and that also smoking is a great part of that. So that's a little bit on the extent of the problem. Now, moving towards improving the system, handed out a handout mainly for the purpose of giving people this link here, because this is a document that's on the web that's been put out by the Executive Office of Health and Human Services in Massachusetts that describes the changes to the system that are going to be going into effect in July. And if you have questions about exactly what these changes are and what the rationale for, I would point everybody to this document. There's no way to go into detail, but I did want to just highlight some things. The system involves mass health restructuring into accountable care organizations. It involves mass health creating behavioral health community partners, an entirely new outreach program. It continues to have the DMH delivering high-intensity services to those who have the most serious mental illness, and that involves the new DMH ACCS program. The Mass Rehabilitation Commission stays involved as they have been in terms of rehabilitation and vocational support for people with disabilities, including mental illness. Wanted to make the point that this comes with some significant investment, an additional $83 million added to DMH funding, and over $600 million in investments to mass health in the coming years. And the expected impact of this redesign is for medical, behavioral health, disability, and social service needs to be better integrated and coordinated for the Commonwealth's most vulnerable members. This is a description of what the new DMH ACCS program is going to be. And I want to say a few more words, though, about what the redesigned healthcare system is really meant to do. Many people are aware of this, but I think people in the cancer world maybe don't know. DMH's main service model for the last almost 10 years has been CBFS, Community-Based Flexible Supports. And just to give you an idea what that is, it's a service available to people that meet criteria for DMH services. It involves, in most cases, an outreach team that has people with specialist knowledge in housing, benefits, vocational and educational rehabilitation, substance abuse, and an individual in CBFS usually is assigned to a single person who's their main contact person, but they have access to support from the entire team. The critical thing is that this is an outreach team. It doesn't require that people come to an office. The team is equipped to go out and find people and work on engagement for people that are not really interested in engagement. And essentially will continue to do that until they reach a point where somebody's saying, don't come back, I don't want you to come back. Issues with CBFS included that the contracts did not have any specifications for what exact services should be delivered. It also wasn't level funded for a lot of complicated reasons around the state. And one of the things that CBFS in many cases done more and more of is care coordination, meaning that when they've been dealing with people who have serious medical illnesses, of which there are a lot, as I've just shown you, there's a lot of CBFS time that's been involved in getting people to emergency room, to doctor's visits for assessments. And that, plus the fact that there weren't requirements for what clinically CBFS would deliver, meant that care coordination accumulated a lot of the time of CBFS. But what's going to be different in the new system is that whereas people who had just CBFS in the past will all have two different services in the future. They will, and the most important being that people will have a health care coordinator that for many people in CBFS is going to be a behavioral health community partner. This is a new service, a totally new service that Mass Health has developed to provide care coordination for all one's care, including medical care. So people are essentially going to have care managers whose responsibility will be to interface with emergencies rooms, hospitals where people are admitted, programs where they're discharged to, looking at medication reconciliation, looking at people actually following through with follow-up appointments. Their job is going to be completely around those kind of care coordination issues, which means that CBFS will not, or the new ACCS program will not need to devote as much time to those functions. And that will allow ACCS to deliver more specific clinical care with evidence-based treatments for mental health conditions that were variably served depending on the provider, the part of the state, and individual teams based on people's expertise. So that's just an illustration of the overall system change. Again, I'd encourage people to go and look online if you want to get more information about this program.
The link is in your community mental health resource list in your packet. So if you want to get that link, it's provided for you on the first page of the community mental health.
Great, thanks, Dan. Vicki?
Okay, great. Thanks. So I'm Vicki Fung. I'm a health services researcher based here at MGH in the Mongan Institute Health Policy Center. I work with Kelly a bit and other folks who are developing similar types of models, collaborative care models and integrated care models to address the many complex needs of patients with SMI. Largely my work focuses on health policy, and in particular healthcare financing, and how that affects access to care for patients with mental illness, the quality of their care, downstream outcomes, and their medical spending. So I've been so inspired to be part of this symposium. And I think I feel like a little bit out of place because I feel this sort of cold numbers cruncher. I work with big data sets, and I think my goal here really today is to think about how we take these powerful stories and turn them into actionable evidence, and really think about the type of evidence that we need to move policy. So I think, as Dan brought up, and as many of us are probably thinking in this room, these are incredible narratives and incredible stories, and the work that Kelly has been doing is so inspiring, and it really seems to be making a big difference in patients' lives. So how do we distill that, and how do we then distill that into evidence that can support policy that will pay for these types of care models, right? What kind of evidence do policymakers need and payers need in order to really make these kinds of things sustainable in the larger sense, right? And sort of thinking about how to distill what are sort of the critical elements and the mechanisms that underlie how these programs work. Even thinking about care coordination and the importance of care coordination, I think we all we buy that in care continuity, but how do we measure that, and how do we demonstrate that to people who are making policy decisions? And so it's been great to be here, and I would just kind of want to make that dialogue, just continue that dialogue, especially between all the different stakeholders that are present in this room. As I said, I do a lot of work kind of with large data sets, and I think a lot about payment. And so, with the rollout of the Mass Health ACO, I think it's really exciting, and I think there are a lot of opportunities here. And so I think we need to think smartly, especially at the start of this big initiative, about sort of what are the research priorities, and how do we sort of get rigorous, valid evidence that will speak to the needs of patients, their caregivers, providers, and really speaks to policymakers and payers. I think in terms of the evidence in Medicare on ACOs, it seems somewhat promising, but I think it's all at a very high level. And what we haven't done yet is, again, sort of try to understand the mechanisms that really affect patients. So we sort of, most of it has been really focused on, are we saving some money? But I think that's not necessarily the most important metric. It's obviously very important, but if we're providing more care to people, we're not likely to be saving a lot of money. But we are improving quality of life, and we're improving outcomes for patients. And so a lot of, I think, work that we can do, especially within the research community, to help move this kind of stuff along is, how do we measure meaningful outcomes? What are the outcomes that are really meaningful? And then how do we capture them? And how do we capture them reliably? A lot of the measurements so far, with all of these sort of risk-based contracts, they pair them with quality measures to, I'm an economist by training, so to reduce the potential for stinting on care or cutting back on care to achieve cost savings. But most of these quality measures are really process-based. They're, did you receive a screening? Did someone have one visit after a hospitalization? And these are really not sort of the most meaningful outcomes that we want to capture. They are easy to measure, and in a sense, maybe more fair to providers. They're closer to the locus of control at the point of care. But ultimately, what we really want to do is improve outcomes and quality of life. And so how do we get to a system where we can do that systematically? So that kind of just leads me to my next point. I'm going to try to stay pretty brief. I don't know where we are on time, but I'm a data person. I really get excited about data. So I think there's a lot of opportunities for data collection. There are new opportunities for data collection at the point of care with things like the electronic medical records from patients through mobile health technologies. But we have to be smart about how we use these opportunities. We can't overburden patients, we can't overburden providers, and we want to be measuring things that we think matter. And so I think there's a lot of work that we need to do right now to sort of validate measures and just work together to identify what these important things are. So I guess with that, I just wanted to I'll just kind of wrap it up, and I think there's a lot of opportunities here, and I just want this to be an opportunity for us to keep the dialogue going so that we can generate sort of the most meaningful, actionable evidence.
So before maybe turning to the audience, I can't help but want to ask a question about, your thoughts around new areas to look for collecting data. We had several, as a member of the district, which is the whole group of folks who are looking at what kinds of things are we going to measure from a quality perspective, how might the monies be distributed, et cetera, et cetera. Much discussion around social determinants of health and the importance of this area, which I think more from a public health than from a medical systems perspective, folks have paid attention to. It's discussed by others, mentioned by others yesterday, and even today. In the opening, what's the effect of poverty? What kinds of ways can we address these issues to look at better outcomes? Not quite sure they have great ways to measure that, but part of the interesting piece, I think, around the structure of some of these Medicaid ACOs, sure, it may be hospital systems and those same systems that folks have worked with in the past, but the exciting thing is that many of them are trying to do different things. So they're spending millions on housing, just housing, and other related social determinants that can impact health. What's your thought about, and even that discussion on a federal level of the importance of that, what's your thought about how folks are maybe starting to think about or ways that they could improve measuring those? are collecting that data?
Yeah, that's a great question, and I had a big sort of social determinants bullet point, but I was sort of trying to process a lot of information at the same time. But I've been, so I'm really encouraged by the emphasis on social determinants of health that's sort of with the rollout of the Mass Health ACO. But I think that there's, so I think it's a big step to even start thinking about the social determinants and to incorporate that into payment and payment mechanisms, and then to start collecting data at the patient level. But I think that from what I've seen just, within the partner system, there are efforts to collect some basic information on social determinants of health, food insecurity, housing problems. But these are really pretty basic, and they're collected, maybe on an annual basis if people show up for a clinic visit and they can get an iPad and fill it in. I think what we have less of is maybe sort of more detailed information on sort of how that actually then affects their health and the way they seek medical care, and then the way to sort of address those barriers. And, in terms of, opportunity, so obviously, I'd love to collect sort of richer data on social determinants, but that there's a price to pay for that. You can't ask a million questions when people come in for care. But also, I feel like we're at the cusp, we have a lot of opportunities to link data that we're not really leveraging. So within Massachusetts, we're lucky that we have something like the all-payer claims data set, where we have, sort of medical claims information on nearly everybody who lives in the state. What would be great is then to be able to link that with other social service programs to understand where people are getting help, where people are sort of falling into the gaps, and then how these social programs and community programs affect health outcomes and care, right? Because I think that's a big missing link. And as a researcher, I think we're struggling as we think about these studies that we want to be able to identify the importance of these social determinants of health and approaches for addressing them. And that's a big data gap that we have, is just identifying sort of who's getting what kinds of services.
And just to keep that real for the audience. So what that means in reality is it takes years to even get access to the data. It means it takes advocacy and years and saying, please, can I please get this piece of information over here and information over here? And no, don't get substance use data because that should be private. And don't get, you have to have someone in the mental health system to get this data. And the Department of Mental Health doesn't actually have the capacity to have the kind of computer that they need to process the data. These are remediable challenges that aren't that expensive to fix. But today, as a system, we can decide to say, okay, I'm going to buy that computer, I'm going to send this to DMH, we can do that study, let's stop wasting years trying to get the data and just move forward.
Yeah, that is a great point.
So I do want to see if there are others in the audience, because we do have lots of good time, who have questions or comments. But since you just said that, Kelly, about privacy, I would love for you to, given the energy and the movement of this symposium, as you have placeholders for next year, I would love to have an ongoing, and I often do bring up this question with the state and others, around the importance of respecting one's privacy, but also at the same time, how can we move this challenge of sharing information that doesn't happen, where the behavioral health, mental health history is a mystery to the PCC, who, for many of them, would love to receive it, could understand it, and would love to work then and coordinate better services with the behavioral health, mental health side. So, origins of privacy, what are the best rights? You talk to varied people, including lawyers who are connected to some of the big healthcare systems. Everybody sort of does a variation on the theme of how they interpret it to allow for more of this to happen. Could we do more from a larger community perspective to say, great way to find the respect, but how can we move in a different direction around? So questions, comments?
If I could actually just respond to that, in terms of communication, one of the parts of the restructuring is that DMH is now going to have access to mass health data on DMH clients. So it'll be transparent to everybody what services that Mass Health is paying for are being used by what patients. And the importance of the accountable care model, just so people understand what that means, Mass Health our Medicaid program has always been a fee-for-service program before, meaning that providers see people do procedures, send bills to Mass Health bills, pays the bills. But what an accountable care organization is, it's a movement to a system which is capitated, and the system is given a certain amount of money for each cared for life. And then that system's responsible really for providing whatever is needed to keep that person well. And the fact that data is going to be available about whether people with mental health issues are getting adequate mental health care, whether they're following through with their medical care needs, that's going to be much more transparent than it ever did before. And the accountable care organizations are actually going to be on the line for providing care to keep people well, because the worse they do with that, the more it's going to cost them. So that's part of a new era we're moving into around that.
Yes, I'd like to ask the panel about the role of the NIH in supporting this kind of much-needed research in terms of providing the evidence for the magnitude of our problems, the area of the gaps in our healthcare system that could be addressed. One of the issues here is, with regard to cancer and mental illness, that we have two institutes, the National Cancer Institute and the National Institute of Mental Health. And when we have a subject like this that falls between them, they often don't know how to deal with it. They don't collaborate or cooperate in terms of providing initiatives, RFAs, grant funding, shared funding, and conceiving of projects on a larger scale. I wonder what's happening at the national level. Is there any interest in this issue of cancer and mental illness? And are the institutes cooperating in terms of trying to provide funding for things like you're talking about?
Well, I think that if we can get some of this data and move it forward, one website I'm on continuously is the Healthy People 2020 website, which are our national leading health indicators, and it's the specific focus is healthcare disparities and social determinants of health. And I span between the cancer leading health indicators and the mental health leading health indicators. And unfortunately, our population isn't even up there as a vulnerable population, and under either heading, whether it be cancer or mental health, there's certainly no mention of the medical issues that challenge the seriously mentally ill. So if we can move the data all the way up the ranks, maybe if we got on that radar, that'd be great.
In terms of NIMH, I'm not aware of anything specific around cancer and people with serious mental illness. And I'm reminded of Dr. Dixon's presentation where she described how it took her 20 years of work on her port study to convince the American Journal of Psychiatry that that system's study was worth publication there. And unfortunately, I think that's the general approach in research funding too. It's been very dominated by biological psychiatry research. I think that is changing. People like Dr. Dixon, I think, are in the vanguard of changing that, but I think we have a ways to go.
Yeah, I mean, I'll just speak to that briefly. I think Kelly probably has the best experience of what it's like to apply for NIH funding at this intersection of mental health and cancer care, and it was through NCI. So I think as you said, NIMH is really in the last, say, 5 years or so, been really focused on sort of the biological basis for the disease and less interested in health policy research. That's not to say that it's not possible, but you do have to be very lucky, and you have to be, there's an element of luck to it, and you have to get in it at the right time to the right people. You have to have the right advocates within the system. Yeah.
I've worked at that system for 27 years for the Cancer Institute. I can tell you, I never heard of mental illness as being an important issue for cancer.
Yeah.
And I think you're bringing it out now, and it's certainly an important thing to us. The way to get it into the national discussion is through your congressman. You have to convince them that at the hearings, they bring up these issues and say, what are we doing about this? We, 12% of our patients have serious mental illness, and they're not receiving any special kind of attention to assure that their cancer is treated adequately. So it has to be brought into a national discussion, and that's the forum that gets things done. It gets written into a bill. And, you know, the funding, for the first time in, I don't know, 5 years, we have a budget nationally, and if it's written into the budget, it will get some attention at the national level. But for something that falls between institutes, it's very hard to get any of them to take ownership. So I totally understand that, but I think you have to try to reach our congressmen and our senators and tell them this is an important issue for us in Massachusetts.
I like to think they're starting to hear that. I think I agree with you that, you know, mental illness wasn't talked about at the level of the NIH, but mental illness wasn't talked about in a lot of different places. It was really pretty much in the closet, or if it was talked about, the people who were in positions to maybe move forward and do something with it weren't really listening or didn't know what to do with it. So it does feel like that door is open, and I feel as though, you know, this kind of symposium and much of the work that folks are hearing about, like, opioid crisis. I think there's not a day that goes by where everybody doesn't hear about the opioid crisis. May not agree with the approach necessarily, but it's allowing for a conversation to talk about addiction and other things that folks never talked about on a regular basis. So I think we are moving in that direction, and I'm hopeful that NIH and others will hear. They may lag a little bit behind the rest of us, but I remain optimistic.
Well, on one positive note, at the federal level, I can certainly see in the Centers for Medicare and Medicaid regulations, the new 1118 regulations, that there certainly is an appreciation in the behavioral health care setting of full integration of psychiatric and medical care. So that's a great starting point, because we have a marriage between CMS and the Joint Commission. And so, you know, when you're surveyed, and lots of hospitals are under either behavioral health or hospital standards of care, you'd find it in both sets of standards. So I think that's very promising.
I just very briefly, I think that there's actually a bill in the House floor in Massachusetts about redefining health disparity, health equity, and what that means,
Yep.
and including mental illness as part of that picture. So part of what the work everyone in this room can do, whether you're a researcher, an advocate, person affected, is we can say, we think that mental illness should be included in that disparities group. Because then you can get funded to do health disparities research.
Right.
So the amount of advocacy I've done at the NIH, where you say, no, you need to recognize this is a 30-year mortality gap, we're talking about specific mortality, it's a specific disparity population. That's what leads to funding advocacy. So that's part of the conversation, both in terms of our government and the research conversation.
Yeah, and I would just add to that, there was a legislative committee focusing on upstream promotion, prevention of behavioral health, mental health issues. Was honored to be a part of that work that was presented to the legislature and the governor, and they are now looking, there's yet another bill that's sitting to make that commission's work become a regular fixed versus a time-limited committee to keep doing ongoing work. So not so much focus on the downstream, but on upstream, what can we be doing from a behavioral health, mental health perspective to be doing more in the way of prevention and screening and promoting other thoughts, questions? I know we have a couple more minutes before the break.
Sure. Hi, my name is Qianqi Huang. I'm the Executive Director for Asian Women for Health, and we provide training and peer support and peer education for Asian women and Asian cancer survivors and trauma survivors. So we actually just have a conference last Thursday focusing on the impact of ACOs, and also mass health. And out of the conference, we hear this concern from the community that, because ACOs will be focusing mostly on the sickest population. So what about the people who, not fall in that category? And we have concern about, care coordination they want, but they don't want care limitation. And one thing I wanted to ask all the panelists is that, what about the people, the English-speaking population, like the immigrants and refugees. We know these communities often have, PTSD and serious traumatic experience that leads to mental health issues. So how do we address the cultural and the linguistic needs of this population? And also the concern that certain community have questions about clinical trials and also about the need for disaggregated data. How do you work with the community and meet them where they are to, to address these issues?
So all great questions. I'm not sure we'll have enough time to answer all. I just want to quickly say that I think the ACOs are paying attention to all of the members who are in their population. I think what happens is we often hear about the, quote, highest risk and the sickest because of the amount of dollars, disproportionate higher amount of dollars that are spent. So from a dollars only perspective, and Vicki, correct me if I'm wrong, I think they often talk the most about that group because they would love to see a decrease in the amount of dollars spent, but the same amount or even more in the way of quality for those. There's lots of other work, I think, that's incorporated within the 17, 18 different ACOs that do have a focus that addresses, I think, the needs of everyone. Let me ask any one of you maybe to answer the other question around the sort of cultural aspects that are so important.
Cultural aspects, but before I get to that, I just want to mention, I think there are disparities in coverage. That's certainly an issue. Most DMH clients have Mass Health or Mass Health and Medicare, but there's a significant minority with private insurance, and there are many cases in which the private insurance coverage is not as good as Mass Health. It's a problem. I've certainly seen instances where DMH clients with private insurance do not have access to the same amount of care that Mass Health provides access to. In terms of the multicultural issues, DMH has had a Multicultural Affairs office for a long time, provides translation services for whatever language, and DMH is geographically based, and for our case management site offices that are in areas that have large populations that are non-English speaking or a strong ethnic identity, there's a lot of effort that goes into hiring staff that are bilingual and culturally competent.
I mean, I guess I'd only just add that, I think there are some very real concerns there. So when you think about sort of like large-scale evaluations of an ACO type model, you don't get into the differential effects on different subpopulations. And so I think that's a real opportunity for us to think about community partnerships. I mean, we talked a little bit yesterday about how you can kind of design something from the beginning, like in partnership with people in the community, to really address how things are working differently across different groups of people. Mm-hmm. Yeah.
We have one last question up top.
I'll make one comment about the cultural sensitivity issue from a nursing perspective. There are not so commonly used in newer nursing degrees, and one of them is in global public health. And you can advance from your master's right through to an APRN and onto your PhD, and maybe that wouldn't be a degree that has been embedded in healthcare organizations, some in the past, but I think better use of nurses with that background would be wise.
So I just want to draw attention back to communication between different providers in different care delivery settings. And from a frontline staff perspective or from a group home staff perspective, what can we do to foster communication between the inpatient providers and our frontline staff? Because usually it is really hard to get any information, and I think Gary can speak to that. Say we send out a patient to be evaluated in an ED because they're having an acute psychotic episode, and then they're sent to an inpatient psychiatric hospital. And we're trying to call to follow up on what is happening, if they need any information from us. And everything we get for maybe 24, 48 hours is we can neither confirm or deny that the patient is here. And then we have had instances where the patient is discharged and sent to us in a cab. And we're like, oh, okay. And then 24 hours after, the patient is right back in the ED. So what can we do to foster that communication?
So I actually think it's a multifaceted approach. I think it's a process that's already underway. I think a big piece that has both pros and cons, and I'll be clear about what I mean by the pros and cons. A huge pro is the system's ability to value the folks who fall under the larger CHW, community health worker umbrella, so community health workers, peer bridgers, peer navigators, support navigators, peer counselors. I mean, there's a whole host of different titles for these folks who get it, who care about people, understand the system, and work to help how it is clients, members have this experience and connection to services and systems. While I think that's a great group of professionals to have, I don't think it should be an out for systems to look internally at how it is they don't do things well, and need to also make some changes internally for improving communication and some of the other things that the panelist talked about. So I like to think that the community health worker professionals will sort of set an example for systems to start to think about not just how they hand the work off to this very valuable group, but they start to look at the components of what makes them so successful and start to incorporate it into what it is they do as their own discharge planning and how they, connect with people when they come into the emergency room, address their needs, have a setup plan for when they get discharged, et cetera. So I think that.
I would just add to that I think that the relationship between the inpatient psychiatric world and the outpatient psychiatric world certainly has its issues. I think some inpatient units, for a variety of reasons, I think don't prioritize communicating with community staff. But I think the most common reason for that situation you described happening is clients who refuse to sign a release of information to allow the communication between the hospital and their care team. But one thing that should help this is that one of the jobs of the behavioral health community partner, they are supposed to make contact with the hospital right away if a client of theirs is admitted to the hospital. And they're supposed to be involved in the discharge, including even potentially a warm handoff to who's ever going to be picking up the care. So the behavioral health community partner role is meant to create a link between the outpatient and inpatient world, among other things.
Yeah, I definitely see where Breslin is coming from. I've had instances where I've called hospitals up, and as a group home manager, they won't tell me anything because there's a stigma attached to working just in a group home. The second I call up and I say I'm a psychiatric nurse, boom, I'm getting the information that I need. So I think there needs to be just a lot more respect given to direct care workers. That's just what I wanted to add.
On that.
Last question.
There's resistance. This is addressed to you, Dr. Norman. There's resistance in some of these, like the overseers of the group care homes and such. There's resistance to computer software programs that would help their people. I know this because I have a nephew, a very talented nephew in terms of data collection and all of that things, and I've always been on him. You always work for somewhere where you're going to make money, 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 money. Are you ever going to work for a nonprofit? And he did. He tried 1 year at a nonprofit. I will not mention which one it is. There was so much resistance that he could not implement the computer software design that he designed for them until someone retired. And then the next person accepted probably a different one. How do you handle that?
Kelly's standing here, so I'm sure I'll be able to answer that. It's a
you know, I think it's
complicated
It's a complicated
answer.
question. You know what I think it really speaks to? The fact that when we're working in one system, we're used to doing things in that system, and we're really kind of resistant to changing it. And I think that even when people come into that system with really good ideas and innovation and energy, sometimes the first response is, that's not how I do it. That's not my job. I'm uncomfortable with that. What about these people's privacy? That's the problem, right? That's why we're here today. Because to change that, we need all of us together to say that doesn't make sense. Let's think about what the most effective solution is. Let's partner with Vicki and do some actionable research that can change policy, right? So thank you for that comment.
Yeah.
And I'd really like to thank our whole panel for the really thoughtful conversation about how we can.